Dr. Howe is going to moderate this session. So, Dr. Howe, anytime you're ready, we can get going.
I was suggesting that maybe Thor would sing for us, but
yeah, maybe a comedy act for me, Jim.
Yeah, well, you do not want to hear me sing.
All right. Well, so Tricia has been compiling these questions, and I put them together, and I will pose them to the panelists. And occasionally that person will be myself. But anything hard, I'm going to send to Thor or Odo, just as a warning. So the first question that we saw in the chat was, I'm going to direct to Dr. Hap-Donnerson. If a patient had a liver metastasis removed, how do you decide whether to use a CT scan or an MRI to monitor for growth? Is one preferred over the other for accuracy? And what about the problems of getting radiation with scans over and over again?
So excellent question. So I would say for most patients, we probably use CT just because they're easy to get and quick, but there is a little bit of associated radiation. MRIs are probably better in picking up smaller tumors in the liver. And so I think it's probably more important to just stay with the same modality with CT and follow up with CT, or if you're using MRI, follow up with MRI. If you're switching from one to the other, you may sometimes see some differences. I think a carefully done CT is probably sufficient in most patients, but there are always going to be those where the liver is just difficult to evaluate with CT, or someone who cannot have a CT contrast for whatever reason, then we might want to use an MRI. As for the radiation from a CT is probably is very low. But if we're talking imaging over the course of like a decade or two, I might prefer MRI there.
Yeah.
But I think both are good options, and CT is probably sufficient for most.
And Thor, Jim, may I just ask Thor how does he assess liver tumor burden semi-quantitatively, and how do you do that at your center?
Yeah, so that's a very simple question. We don't, or what is a simple answer? So we don't quantitatively do it, and so I end up been at the University of Iowa as well, where that's more routinely done. Our radiologists do not report a number; they just have a descriptive a description of what they see. They don't provide us with liver tumor burden. So for my patients, occasionally if they ask for it, I can usually do that just by looking at it myself. So that's something that I like seeing in the reports, but we just haven't done that yet.
Thank you.
Tom is asking for just to tell us the percent of tumor burden, which helps us decide sometimes about whether surgery is a good option or embolization versus PRRT.
So, thank you, Jim.
Wait, Tom. No, I was just restating what you asked, Thor.
Oh.
I have a different question for you. Is there any guidance on how one can reduce recurrence following a particular nutrition plan or diet? I asked you that one because I have no idea.
I'm not sure. I'm not sure I do. I remember, and I'm sure the many of the folks in the audience remember Monica Warner and the great effort she made on terms of carcinoid type of diets. I think, Jim, this would be up your alley too. I think just making sure nutritional status is assured. I personally do not encourage or recommend one diet or another. I know that they're sensitive to precursors for serotonin formation in their diets, like bananas and walnuts, which can increase. But those levels, the different, those kind of nutrients, really, it's kind of like putting it in the ocean, a drop in the ocean, because folks that suffer high serotonin, that's not going to impact the levels that much. And so I usually don't recommend. Maybe Thor does. I don't usually.
No, we typically don't either. That said, I wish there was that we knew more about the sort of the role of diet in the management of neuroendocrine tumors. I feel that we're a bit behind the Europeans with at least publishing on this and actually educating dietitians and others on it. So. We all know that patients frequently ask about these questions, and I would love to have a dietitian who specializes in neuroendocrine tumors, and we will eventually be training someone for that, but we don't have that yet.
Okay, now I gotta say we have about 40 or 50 questions, so we're gonna go with a kind of more rapid fire answers so we can get through all of them. So the next question I'm gonna take, and I'll answer it in rapid fire. Would breast neuroendocrine tumors be treated any differently than another breast cancer? And the answer simply is yes, because these are commonly metastases from other sites, specifically the small bowel is where I've seen them most come from. And there, a local excision would be adequate. Don't need to do sentinel lymph node biopsy, don't need to think about adjuvant therapy with estrogens or anti-estrogens or chemotherapy. So it's sort of a local problem that is a metastasis from somewhere else.
Yes.
Okay. Well, Tom, let's just keep
Go
going through the questions.
I'm sorry.
Thor, the next question is, how useful is chemotherapy, CAP-10, specifically for non-pancreatic tumors?
So a great question. For non-pancreatic tumors, not nearly as effective as for pancreatic tumors. Some activity in lung neuroendocrine tumors. For small bowel neuroendocrine tumors, less than 20% response rate, so not much of a role for chemotherapy in the most common small bowel.
Okay, Tom, here's a good one for you. Thinking of a multidisciplinary neuroendocrine tumor team, is there a specialty who should be the coordinator or decision maker, such as the oncologist, the surgeon, and they didn't mention the endocrinologist, Tom.
No, I know. I felt again. I neglected, and like I said, the paradigm has changed greatly, and I think Thor would agree with that, especially in Europe. If you look at the centers of excellence in Europe, 80% were run by gastroenterologists and endocrinologists 15 years ago. But that paradigm has shifted now more toward medical oncology, as they've come into their own with the new developments of the immune therapies. The answer is, I think yes, there should be a director. I think, though, at the same time, they're co-directors. Ours, as Jim knows, he and I talked about this 20 years ago and set up a clinic together, and that's how it began. We were blessed to have Dr. Joe Dillon, an endocrinologist, Dr. Chanda Saharan, who medical oncologist, and really we kind of look at things as a group. And our day in the clinic virtually has all three of us or four of us there, so that there is an interaction that may lead to the tumor boards, as Thor talked about. But I think there should be a given director who has the responsibility to mind the issues in terms of making sure space. Well, just the issues of running a multidisciplined clinic.
Okay, Tom.
Thor?
Let's follow up. Well, we don't have to get everybody's opinion on every question, or we won't get to them. So
go ahead.
they'll feed off of each other, and there'll be some will repeat. This is a question that's sort of related. Should a patient with a neuroendocrine tumor specialist, should they meet with a neuroendocrine tumor specialist prior to having surgery scheduled? And I guess the implication is, if they met a general surgeon who recommended surgery, but he's not a specialist in neuroendocrine tumor, should you see a specialist? And I think that's never a bad idea. But I think it really depends on whether the tumor is really symptomatic. So if a general surgeon is meeting you because you have a small bowel obstruction, then there may not be time to seek out another opinion. If, on the other hand, you were diagnosed with liver metastases and suspicious for a small bowel neuroendocrine tumor, you probably have time to meet with a team of people. And I think going to a center of excellence is never a bad idea. It's never bad to get a second opinion. You may decide to have your surgery locally, and that's fine. But hear what people have to say, because sometimes people don't see that many of these tumors, and they may not be an expert on all the different sites that they might need to treat. Thor, here's a question for you. Is the primary tumor the only one which will produce metastasis, or can metastases metastasize?
So I think metastases can certainly metastasize, but this is a debated topic, and we may get more into it later, whether we should remove the primary tumor or not. There are some actually fairly good arguments for that. But as for this question, yes, metastasize can metastasize.
Okay.
Very interesting.
Yeah, there's a lot of debate on that. I'm not. I think I believe that, but probably not as much as from the primary. But that's controversial. Odo, let's talk about gallium-68 for a second.
Yes.
How often do you recommend getting a gallium dotatate scan for somebody who has essentially stable disease and? Well, it's the same question. Okay. How often do you recommend getting a gallium dotatate scan?
So, I think in terms of frequency, and as you said, if things are stable, and this is where I think the markers, and please comment quickly, Jim, on this, because I think the markers really helped in that decision. That especially if the markers persistently stay stable, let's say serotonin's high, but it stays stable high, or pancreastatin is elevated, but it's stable elevated, and you're following chronically, I don't think there's a need, or even if there's an increased symptoms, I don't think there's a need to do a 68 gallium. I think I clearly do it with intent to treat again each time if we're going to do PRT. But and we do it initially in terms of the workup and evaluation. But I simply just don't do it that often when you have CT scans, because they are the gold standard. You can't have, no matter what they say about a scan, you're looking at something shiny. You're not looking at disease per se, in terms of anatomy. So And
Tom, insurance companies aren't going to allow you to get those all the time either, right?
No, not at $18,000 a pop. That's what the dotatate net spot costs, and it's prohibitive. I mean, and I think in the C what is it, the C14, the carbon 14 scan offers longer durability of the activity, so they can send it around more, but I don't think it's going to add to decrease costs at all. So I think it's still going to have to be judgments. Thor? Yeah.
Well, we don't need to keep. That was a great answer, Tom. We don't need to get everybody to weigh in on our
other
questions. Yep. Tom was mentioning the copper scan, which is now going to be. You're going to see this more and more.
So I said carbon. Sorry.
It's a very similar scan that the isotope may last a little longer. So for communities that can't afford to get the dotatate because it has a shorter half-life, they might be able to get the copper soon. So keep an eye on that in the horizon. Yep. Next question I'll take is, what percentage of breast neuroendocrine tumors? Again, back to the breast. Again, these are metastases, and unless Thor or Tom know of cases where there are actually neuroendocrines that actually started in the breast, I'm not aware of that. I think they're almost always metastases.
The only thing I know, Jim, on that, and there was a literature that I looked up with a case, in-house case with a primary. It was called a primary breast. That's really kind of one a degree. I think they make a point out of the staining, the intensity of the staining, as being a differential whether or not it was a primary. But like you said, I think it's very gray. And I think metastasis, you mentioned carcinoid. I've seen at least 5 metastatic medullary thyroid cancers as well that predilect to the breast. And so I tend to favor your interpretation and keep looking for the primary.
Yeah, okay. Well, here's a good one. I'm going to ask Thor this, but Tom, you're certainly going to want to weigh in after that. What determines when sandostatin shots should begin in somebody who's had surgery for a small bowel primary and is not showing any symptoms?
Well, so here's my take on it. So if there is no residual, if it's a low-grade tumor and there is no residual disease at the time of surgery, I do not use therapy. So I never use therapy after surgery if everything has been removed. If there's low volume disease left, I talk to the patients about either waiting and until things grow or starting therapy. If there's a lot of disease left at the time of surgery, let's say someone has small bowel resection, but there's still lots of liver disease, I am much more inclined to start therapy. I probably wait more than many other of my colleagues and not start.
Tom, you like
Yeah.
sandostatin, so what's your take on it?
Well, it's true. I've come a long way, if you will. I was accused at one time of having relatives on it that didn't need it. So I really have come. I think Thor really put it well, very well. I think symptoms, I think I would do empirically. You know, even if the symptoms are subtle, but they're clearly they're things that reminded them of their carcinoid, I would treat in that instance for symptoms. But I think Thor is right. And I guess that has to do with the end stage, or not the end stage, but the ultimate. You know, does it impact? It certainly can impact the anti-proliferation effect, and that's been worked out with clarinet. But again, I think it's individualized, as Thorpe said, and I tend to agree. I guess if there's if there's known residual disease, especially in the liver, if you came back, Jim, and told me you took out 6 or 7 or 15 big ones, and you left something there, I think I would favor putting them on it, if not giving them a holiday if the marker stayed constant.
Well, Tom, let me follow up on that, and Thor as well, because I think anybody who's had liver disease has probably micrometastatic disease in the liver remaining. And I think you could argue that everybody who has a liver met maybe should be on it, which may not be true of people with nodal mets. Do I have that right?
Go ahead, Thor.
Here's the way I look at this. And I completely agree with Jim. You probably never clear the liver of metastases. Essentially, with the liver surgery, the way I explain it to my patients is that you're setting back the clock, possibly by a number of years. So for me, most of these patients will end up on injections at some point, but I typically wait for tumor progression if there's low volume disease, and then I start the injections. Because although the injections are well tolerated, there are some side effects, and they are very costly. So not just the cost of the actual drug, but the cost to society with and insurance plans. So I'm very mindful of that.
Okay, well, let's move on so we can cover more questions. That was great from both of you guys. Tom, here's a good one for you. Is it safe to drink non-alcoholic beer or wine when you have lesions in the liver? And what about beer that's labeled as 0% alcohol?
Well, I certainly have no negative comments on that question. I do think even the alcohol clearly, and that's one of the E's I didn't mention that Ms. Dabbs was referring to, because there is a catecholamine jolt, and it probably mediates the release of serotonin. And what I instruct the patient, they do like social. In fact, I had a patient from Venezuela who came over and said she regrets most that she can't have a glass of wine with her father at supper time. And the bottom line was, I just told her to take 100 micrograms sub-Q of octreotide and wait 30 minutes and have her drink. I mean, same way with exercise. Somebody's a heavy exerciser and gets fatigued. You just give them sub-Q, and it's protective for symptoms. And at 30 minutes, it peaks. Its peak action is 24 to 30 minutes. So That's what I instruct.
0% alcohol, Tom. If it's no alcohol, is there any risk? Can you
No, I can't imagine there's risk unless there's something in the hops that I don't know. But I'm just saying, no, there's no risk to that.
Okay.
Unless Thor, I don't.
Well, we don't need to. No, you got it, Tom.
Okay, so
All right.
okay.
Thor, I got a different question for you about lung nets. This individual asked a question. I suppose they were told they have mets to 4 liver segments. What does that mean, and what are the options for treatment?
So for lung nets, so I approach them much like I would approach the pancreatic or small bowel nets. If the lung net, if the primary tumor in the lung can be surgically removed, I think we should have such patients seen by a liver surgeon such as you, Jim, if there are limited metastases in the liver. So resecting the primary lung tumor, resecting the liver, especially if these are low-grade, what's called typical neuroendocrine tumors, is definitely worth doing. I think these should all be presented at tumor board.
Yeah, they tend to be low on somatostatin receptors, right? So PRRT is not as common an option for those people.
So interestingly, we just submitted this to ENET, says that of the 33 lung net patients that we did somatostatin receptor imaging on in the last 2 years, every single one of them was positive.
Wow.
That's actually way higher than I would have guessed 50%.
Tom, that's not really our experience, is it?
No, well, it might be with the typical carcinoids, but no, it isn't. 46% of the atypicals contain the receptors, the somatostatin receptor subtype 2. So, it's less than half that have the receptors in that group, whereas they overexpress the CXCR4. So that is were those all typical, or were they mixed group?
Both. There was every single one of them. So these were like 100 patients. We did somatostatin or dotatate scans on 33 of them. Every single one of them was positive.
And so one of the things that Thor and Tom are talking about different assays. Thor is talking about positivity on scan, whereas Tom is talking about looking at the receptors under the microscope by immunohistochemistry.
Yeah, yes.
But we don't need to go into it in more detail, but just to understand that with lung nets, the options might be more limited, and surgery certainly is an option.
Yes.
Well, Tom, here's a good question for you. This is a tough one. Not really that tough for you, but with regard to liver lesions, what characteristics dictate whether they should use bland embolization or PRRT for a treatment plan? And I think that can be extended to any kind of embolization versus PRRT.
That is an excellent question. For myself, and I think it's pretty well established that bland embolization is a sudden cessation of blood flow to the tumor, and obviously the decision for using interventional therapy has a great deal of input into where the one or the other may be more feasible. But I think that having seen the effects of bland embolization, to me, I think age has a lot to do with which ones should be preferenced. The older, the more senior individual, I think that it could be a very traumatic problem in terms of morbidity with bland embolization, whereas there's virtually none. Even the Y90 spheres done later, versus an earlier age group might be the preferred way, because they look at 10-year studies with radiation effects, and when the person's in their 70s particularly plus, I think the lower morbidity prevails in my decision if it's feasible to do one or the other.
Maybe I can redirect this question to Thor as well to get his take, but I would focus specifically on the size of lesions. I think that could be one of the most important determinants. Thor, what do you think about that?
So I'll speak for our center and our experience. We do not radioembolize, period. And so not for neuroendocrine tumors, we do it for other tumors like cholangiocarcinomas and liver cancer, but for neuroendocrine tumors, we have not, to my knowledge, not radioembolized in the last 5 years. Everything is planned embolization.
I think maybe I'm misunderstanding the question, but I guess I was interpreting embolization versus PRRT.
Excellent. That's actually an excellent question.
Yeah.
So that and that goes to the location of the tumor. Let's say if you have well-defined liver tumors that you can actually embolize with whatever is the embolization method of your choice. And I'm not saying necessarily one is better than the other. A lot of this is institutional preference. If you have localized disease and surgery is not being considered for whatever reason, embolizing is a good choice. I actually think that we underutilize embolization.
Okay. All right. So another question came in. This, I guess, is for me, and it has to do with patients who have recurrent blockages after surgery. Is there a recommendation to treat those? And, I guess I would just say that anybody who's had abdominal surgery can get small bowel obstructions. And the body reacts to having surgery by forming what are called adhesions, which are these thin, almost saran wrap type connections that can stick the bowel down and cause kinking. And if the problem is from these adhesions, and a lot of times you don't know because recurrent tumor is still an option, but a CAT scan can help sort that out, although it's not perfect for that. Then the advice I would have for patients who have recurrent problems is to go on a low fiber diet and keep well hydrated, and just avoid foods that might have difficulty getting through narrow areas in the bowel. Assume there's a little kink. And so the things that are the worst offenders are things that are high fiber things that we can't digest. We don't have an enzyme in our body, for example, for cellulase, which cows have to help digest grass. We don't have that. And you think about certain vegetables that have a lot of vegetable matter that can't be broken down. These are probably the worst offenders that are going to get caught up in these areas of kinking. So avoiding those, keeping well hydrated. If you're throwing up and they're getting dehydrated, you should go to the hospital, get IV fluids. Sometimes they put a tube down your nose to decompress the bowel. Most of the time, these things will resolve. And sometimes, though, you'll need surgery for that blockage. Okay, Tom, question for you. What can I do to help decrease the possibility of metastases?
Ooh. Let's see. I think, I just go back a step. I think in our experience, surgery, Dr. Zollinger used to say about gastrinomas, surgery were the first three options. And I think the effectiveness of the initial surgery will help dictate the timing of metastasis. And Jim, I mean, that's something we didn't even talk about today. But I mean, if you look at markers before surgery and then you look at markers after surgery that you do, and they go completely to normal and just stay normal, and there is no evidence by CT of any regional recurrence for sure, and maybe 3 to 4 year delay in anything in the liver, to me, it's the expertise of the surgery.
Yeah, I agree that I think the primary site is where the Mets come from, but as far as being on a diet or some other magic formula, I don't think there is one. Thor, does the mean lifespan increase if you've had treatment with PRRT, if you have a small bowel neuroendocrine tumor with metastasis to the liver? And a sort of related question is, what's the life expectancy for somebody with a neuroendocrine tumor? We only have 5 minutes left, by the way, so we're going to...
Great question, so I'll try to be brief. So as for the PRRT, if you have disease that is not removable with surgery, yes, PRRT will result in longer life expectancy. So we don't have a fully mature data yet, but looking at the available data certainly suggests strongly that those who get PRRT live longer. So, and the other question you said was for, remind me, so.
Oh, just the general life expectancy.
Yeah. Great. So general life expectancy again is highly dependent on the amount of the disease and the tumor grade and the clinical behavior observed over time. So there are grade 2 tumors that are very indolent. There are grade 2 tumors that are very much more aggressive. So I'd say for small bowel neuroendocrine tumors, metastatic small bowel neuroendocrine tumors, life expectancy is probably more than 10 years now with the available drugs. With for pancreatic neuroendocrine tumors, advanced metastatic, probably somewhere between 5 and 8 years, although it's highly dependent on what study you look at. There are some studies suggesting, not proving, that if your treatment is at a high volume center or through a neuroendocrine tumor center of excellence of some sort, the outcomes may be better, but that could be because of more options at those centers, or it could also be what's called selection bias, that the people who go to those centers may have done better anyway. But here's the key message. Life expectancy in neuroendocrine tumors has improved steadily over the last several decades, and there are people who are living longer than they've ever done before.
Thank you, Thor. Okay, here's a question. If a person has a neuroendocrine tumor originating from the small bowel that has metastasized to the liver, can it also spread to the pancreas? And is it then considered a PNET? And I think I'll answer this because we wrote a paper where we described 11 patients who had tumors in both the pancreas and the small intestine. And we were able to trace them back using immunohistochemistry and RNA, that 2/3 of the pancreatic neuroendocrine tumors originated from the small bowel, and about a third probably started in both places independently. So yes, they can spread to the pancreas. If you have metastatic neuroendocrine tumor to both the liver and the pancreas, the urgency for removing the pancreas is somewhat reduced. You really got to look at the whole picture. So it's an unusual circumstance, but it does happen.
Yes.
So Tom, I think let's ask you, this will be our last question because we're about to run over. And I think this is a really good one, and people struggle with this. The question is, getting a second opinion is usually a good idea. The downside could be 2 divergent recommendations from 2 highly qualified clinics. Then what do you do?
Well, I think what you, in that instance, and I must say early on, let's say 15 to 20 years ago, we did have folks that were very thoughtful and would go to probably 2 or 3 centers to get opinions, and would at the meetings contrast. And they most of the ideas and opinions were in line with what we all know to be the options of care, and they weren't unreasonable. And I always say, all of the options are good options, but the good options at the wrong time make a bit of difference. And then I would say this is how we would approach it, and as you know, and I say, and when I reach that point and they make a decision or they're thinking about surgery as a first option, we set that up with you. They can think about it if they wish to do it. If they do it, then it goes another step. So I never take anything away in that or compare and contrast. I just say, this is what I think your best option is at this time. And, and then say that that's what we could offer. And that's how I do it.
Yeah. And I think different areas different clinics have expertise in
Yes.
one area or another. And sometimes you're going to be given the perspective of, if it's very medically oncology driven, you may just hear about medical oncology therapies. If there's a surgeon there, they might talk more about surgery. Thor, what do you guys think at the Mayo Clinic?
Yeah, so I think sometimes we're actually looking at the treatment options that are different, but the question becomes more timing. So what you do this first and then that. So I think more often than not, we're actually talking about the same things, and
Yes.
they might be coming at it from different angles. So the end result, as Dr. Rodriguez said, might actually end up being the same. So at the end of the day, all of our goal is to improve the outcomes of our patients, and we may just come at it from slightly different angles.
Yes. And the other thing, thank you, Thor. I agree. And the other thing I try to stress is that you should never lose an option with an option. And and I think, once they know that this can be done and you won't hurt yourself for another option down the road, that also sort of validates the patient's efforts in terms of what they were seeking.
All right. Well, it's been a great panel. You guys gave great talks. I really enjoyed this. Bob, are you back to talk to the group? I think we'll turn it over to you now.
Yes, here I am, and thank you very much to our fantastic panel. I really thought this was a great morning session and good Q&A session. Just so the audience knows, we're attempting to record this whole thing, so with any luck, it'll be available on our website within the next week or so. Right now, I'd like to let everybody know we're going to take a little bit of a break at 1:30. We've got kind of an interesting game that's going to happen so that we have a little bit of entertainment between all this intense brain building that we've been doing. And then at 2 o'clock, Dr. Aman Chauhan will be back with to kick off the afternoon session with some information about clinical trials. So once again, thank you. And I'm sure we'll see you again soon, maybe next year at the National Cancer Patient Conference in Atlanta, if it is safe to do so.
Wow.
Thank
Take
you very
care,
much.
guys.
Thank you very much.
Thanks,
Really
everybody.
appreciated this.